Hey crew, welcome to the MMOA podcast. My name is Shelby Blankenship. I am one of your TAs in L2 as well as live and a physical therapist. And today we are going to talk about a case study that I had related to chronic shoulder limitations. Now, when it came to this patient, she was in her 80s and she had a right humerus fracture that occurred about a year ago due to a fall, and it was not surgically repaired due to lack of displacement, but also lack of bone integrity, where they didn't think it would do very well post-op. So they decided to do just kind of keeping it in a protected sling position for a while, and then just gradually increasing range of motion once bone healing was completed. I saw her after that episode had happened, and the biggest emphasis that we had was managing swelling for sure in her right upper extremity, but also just trying to maximize strength and range of motion in the ranges that she could tap into at the time. And she did pretty well. I would say it was not like she got full range of motion back by any means, but she was able to be functional with that right arm and do everything that she needed to do at the time. Now, fast forwarding to a year, which is the current day, she came in and she was very limited in right upper extremity range of motion when it came to flexion and abduction. Her flexion on initial eval was 81 degrees and abduction was only 65 degrees. So pretty limited. Definitely was not getting to head height, was having a difficult time like washing her hair, getting clothes on, reaching overhead to put dishes up, that kind of thing. And then when we did the aptly external rotation, range of motion was to C6, and then aptly internal rotation was to T2. We did another couple of metrics to use for goal setting. Spady was one of the big ones we used, and she was around 43.1%. And then we noticed some severe weakness when it came to shoulder abduction, shoulder flexion, and shoulder external rotation, besides those functional movements that we had mentioned previously. So the big three boxes that we wanted to focus on with this patient was range of motion, overall just strengthening, and then maximizing functional capacity. So I'm going to kind of go through the different ways that we went through each of those three boxes. And the biggest thing here is this is not like an all-inclusive list, but this is what worked for this patient. I have seen this patient many, many times for other things over the course of the years. And she is somebody who has really struggled with chronic pain, so much so that she has had multiple spinal stimulators in the past and has had a lot of use of medications in trying to regulate her pain. So that was something that I knew kind of going into this, and something where I knew she really struggled with, I'm going to say, what we would consider kind of like pushing herself into discomfort. She's just a very high irritability patient. And so we're just kind of taking that with a grain of salt. So when it came to range of motion specifically, and we did a lot of active assisted range of motion exercises when it came to using a cane. Obviously, flexion and abduction were big ones that we were really trying to emphasize, because she definitely has, when she had the right humerus fracture, it was more anteriorly, and it definitely feels pretty gummy when it comes to her range of motion, but also just like to the touch. That tissue is pretty gummed up, doesn't really like a lot of mobility. It can move, but it's just pretty uncomfortable. And so when we kind of worked on the range of motion, she is somebody who used to be a massage therapist. She really likes touch, passive range of motion, active assistive just range of motion in general feels really good for her. PAs feel really nice. So we definitely kind of incorporated that with some deep breathing just to kind of help with relaxation, just to, her nervous system tends to be super upregulated, and that tended to feel really nice for her. And then as we kind of went through the plan of care, and we transitioned to doing more like dry needling and cupping, which she really likes. She's definitely somebody who likes to be in the more like calm exertion versus like sweating exertion. So we've used those tools, and then we kind of transferred into some strength portion. Now, the strength, we started with banded isometric exercises at the very front of the plan of care, and then we kind of transferred that into more like dumbbell, like lateral and front raises. We did some shoulder shrugs, trying to access all the different ranges of that musculature, but also the different positions of it. And really, when it came to strength training, we tried to combine so much of it with functional training to just translate to stuff that she could do at home to give her more confidence in what that looked like and what capacity she actually had. So when it came to functional, which really kind of tied in like the range of motion and the strength piece, the biggest ones that I feel like people never tap into when it comes to upper extremity is like a sled, push or pull. It is so nice to kind of actually get people into more of a shoulder flexed position, but it gives them resistance to where they're kind of braced all over and not just pushing out with a band or just with a dumbbell. It can be really, really nice in that push and pull position and requires quite a bit of midline, which a lot of people don't get a lot of training in just because it's hard to cue sometimes, especially if you're not doing things like carries. The other ones that we really like doing were plate stacking. So what I use is our little change plates. I've got some that are 1.25 to 2.5 to 5, and I've got a little setup that looks like a countertop kind of kitchen area, and people will practice taking items from the kitchen counter or lower and placing them at head height, above head height, et cetera, et cetera. And it just kind of mimics a lot of overhead reaching, but also kind of gives them an idea of what their actual capacity is when it comes to overhead reaching. And you can do it over and over again to kind of practice endurance, really trying to get that elbow stacked so they are kind of mimicking a strict press versus a push press and being able to cue, hey, this is the time when a push press is really, really helpful, especially when you're getting more fatigued, when you're stacking a bunch of plates. Most plates are not going to be in that 2.5 range, but it's going to allow us to kind of build that capacity so that when they do the items at home, it's a lot easier. We also do the landmine press. If you haven't taken our older adult live course, we have a lot of really great iterations of how to introduce that with a PVC pipe from a Swiffer mop all the way up to actually using an actual landmine. But the whole point is that you're doing a more closed chain push, and you can start more in that horizontal plane and then work your way up into a more vertical plane, creating more range of motion capacity, but also allowing that patient to really isolate that area without usually exacerbating much pain. We also did a lot of elevated push-ups, whether that was countertop and wall, and then kind of working our way down as far as height goes. And then especially when it came to the posterior shoulder, we really emphasized doing ring rows because it allowed that patient to get into more shoulder flexion capacity, and it allowed them to, kind of use body weight to kind of help decide how much oomph they needed versus not, walking their feet in versus out to allow more range of motion in that shoulder, but also more strength requirement. And then when it came to the ring rows, we would actually end up progressing people to more of a gorilla row because it allowed them to be in more of that kind of like deadlift position. And it was very functional of like pulling items out of the dishwasher or pulling weeds or any of those kinds of items. And you can add that in with like a farmer's carry, which can be super, super helpful with carrying groceries and really building up that grip strength, which as we see when people have, like shoulder issues, it tends to not just be isolated at the shoulder. It can kind of go down the chain into the elbow and hand, limiting that capacity for other items. The last thing that we really focused on when it came to functional strengthening was carries, like I mentioned, the farmer's carry, but not stopping there. We also worked on waiter's carries, we worked on goblet carries, and then we did front rack. And I can honestly say I don't usually tap into front rack nearly enough. And this was one where it was so helpful because it required shoulder flexion, range of motion, and stabilization. And being able to maintain that for a few laps is pretty challenging. And it's one of those that I feel like it's kind of like a duh when we think about like a CrossFit class or anything like that. We like use that when we do lunges or doing squats or anything, but just a pure front rack carry is so helpful with maintaining that shoulder flex position and having it rest a little bit on the shoulder so it's not a complete loaded position like you would do like a waiter carry or something like that. So ultimately, when it came down to discharge, we had 12 visits with this patient, and those were the kind of progressions that we went through. She ended up going from 81 degrees of flexion up to 110. Abduction went from 65 to 85. Her aptly external rotation went from C6 to T2, and then internal rotation went from T12 to T10. And her SPADI ended up reducing from 43.1% to 23%. So she had a lot of really great gains not only in range of motion, but strength. And she's also someone who really struggles with doing her HEP. So I knew that the majority of the movement that she was getting was in session, but she even noted how much more she was utilizing her right arm, which is a huge win when it comes to, cooking at home, cleaning at home, and doing those kinds of things. So just to kind of reiterate, we went through a case study all about chronic shoulder. This patient happened to have a right humerus fracture about a year ago. And then we were kind of seeing her after the fact when she'd had some range of motion limitations that had kind of creeped up, as well as some strength limitations, and just kind of going through those progressions of starting nice and simple with the cane and doing some manual techniques to kind of get some buy-in, and then incorporating some banded isometrics to kind of at least mitigate pain, but also trying to create some strength while buy-in was still kind of questionable. And then translating that into more functional items like a sled push and pull, plate stacking, landmine pressing, doing push-ups, ring rows, gorilla rows, and then ultimately some carry options as well. Now, when it comes to future classes that we have coming on to the older adult and MMOA portions of our curriculum, L1, we are going to be starting back March 17th to September 16th. And then live, we have a few options. March 21st, we're going to be in Lincoln, Nebraska. March 28th, we're going to be in Bismarck, North Dakota. And then April 11th, we will be in Virginia Beach, Virginia. So we hope to see you there. Hopefully this was helpful, and I hope you guys have a good rest of your week.